Hello, everyone. As you know, if you've been following us for this month, we are talking about thyroid dysfunction and hormone testing and how it correlates with some of the laboratory diagnostics available through SpectraCell. The first week, of course, we talked about the micronutrient test and connect that to thyroid testing and how that would actually present with a thyroid patient. Then last week, of course, we talked about cardiometabolic and how diabetic markers along with cardiovascular markers are often presented or correlate with thyroid testing. And today we're going to talk about various nutrients and how they actually play a role and are affected by various hormones in addition to specifically thyroid hormone or thyroid function. So once again, we're going to do a preview a little bit for those of you that have not joined us earlier this month about SpectraCell's micronutrient test. Is that SpectraCell does use the lymphocyte to do the micronutrient testing, which has a lifespan of approximately 6 to 9 months. And so this is why you can retest the patient at approximately 6-month period for follow-ups as you are evaluating these individuals. And as we all know, there are several things that affect our nutritional status, whether it's the previous pathologies or present pathologies that patients have, whether it's medications that they're taking. And I want to emphasize not just prescription medications, that non-prescription medications as well will affect this. And we'll talk about some of those today on how some of the simple or basic medications taken over the counter have a role with possibly thyroid involvement or present very similar in regards to the signs and symptoms of thyroid and where you want to rule this out. Then, of course, dietary changes, and we all know that a lot of people out there today are following various dietary regimens, whether it's vegan, a paleo diet, a Mediterranean diet, a gluten-free diet, and all of those come into play, especially the gluten-free diet. I'll emphasize today how when people are on a gluten-free diet, why they may have an increased tendency towards thyroid dysfunction and possibly affecting their overall health. Exercise, of course, is it light, moderate, or heavy exercise? That's going to play a role. Of course, stress. When we talk about stress, we don't want to just talk about psychological stress. We do want to talk about physical stress like exercise. And even though we encourage exercise in everyone, that we do have special effects with that and how it does play a role with various conditions. And we're going to talk about one today in regards to thyroid dysfunction and how physical exercise could actually lead us down the road to autoimmune diseases. Sleep, of course, genetics. As you know, there's a big push right now for genetics and the role of genetics in our nutritional requirements. Nutrient interactions. This is one of the biggest things and most important things that I emphasize to clinicians when I talk to them or even my patients, that why we need to do follow-up testing, that we just can't do an original testing on an individual for their nutritional status and then supplement them and just let them go about their business, because various nutrients will interfere with other nutrients, especially if we give therapeutic dosages. And then the absorption of our nutrients from the food, whether it's macronutrients or micronutrients, and once again we'll talk about that and how there are certain indicators on the SpectraCell testing that will help correlate with that and also lead us down the road to other possible relationships. The SpectraCell report, as you know, not only notes functional deficiencies, but it also notes borderline deficiencies. And of course, this is the front page that you would see with your patient when you're looking at their results. And then, of course, we're going to break it down individually, row by row, and show you how to compare those. But the one thing I want to emphasize, and I try to emphasize this on every webinar, is the borderline deficiencies are just as important as the functional deficiencies. In fact, I see this a lot in my patients. I hear this a lot from clinicians around the country, that often their borderline deficiencies have a strong correlation with the patient's signs and symptoms. So you want to treat the borderline deficiencies just like the functional deficiencies. And if you don't, what's going to happen is those borderline deficiencies on the future testing of the patient may eventually become functional deficiencies. So when we were looking at this test, once again, you will see a bunch of graphs in addition to numbers. And of course, the blue portion of the graph tells us that the patient is deficient. If the square is in the blue, it's red. If the square is in the yellow, it's black. And of course, if the square is in the white portion of the graphs, it's green. So we always want green squares with every one of the nutrients. And as I tell my patients, and you've probably heard me say this before, is we do not want any black squares or red squares. So we have to resolve those particular deficiencies, whether they're functional deficiencies or borderline deficiencies. This particular marker, SpectraCell, this is a general marker telling us how the patient's antioxidant status is. What's really important about this is that it involves numerous nutrients. And this is the difficulty of keeping this up in the white. So if you have been using SpectraCell for some time and you get a little maybe frustrated with the patient's results and it's difficult to keep them in white, don't feel bad, because when you look at the body and you look at all the nutrients that have antioxidant qualities, you have to keep all of those in balance. And if a person's on medication, if a person's exercising, if a person's eating really poorly, those things are definitely going to cause some free radicals, and then the patient's requirement for antioxidants is going to go up drastically. So even though idealistically we want the patient to go up into the white and stay in the white, it's not unusual for the patient to go up in the white portion of this graph on the SpectraCell and then come down a little bit in the yellow region. Now, once again, this is why you have to look at all the individual nutrients to see which ones are causing that. You just can't assume that's vitamin C or vitamin E or some of the basic antioxidants. And we're going to talk about oxidative stress today because it plays a role with our hormones. And if we don't address that oxidative stress, we are going to have hormonal imbalance, and I think this is extremely important to keep in mind when we are looking at the individuals, and we have to address that. And that's not just with hormonal function, but we know that's true with numerous conditions today, that inflammation/oxidative stress will affect our neurological system, will affect our GI system, and various other systems of concern with our patients. The Immunodex, once again, this is really the first 5 days of growth of the patient's lymphocytes. As I mentioned in the past, for some of you that have been using this test for some time, you probably remember this particular graph. As noted, the LPI is a lymphocyte proliferation index. They have changed it to the Immunodex. And once again, any nutrient on this test or any nutrient that has immunological function will affect us. And once again, we will talk about some things today and how they affect us and how they can present with the thyroid and other hormone relationships. So this is once again the first page of graphs, and as I mentioned, you'll see the white, yellow, and blue portions of it, and we're going to talk about each of these rows in a second. And I'm going to give you some idea of where we're going down the road today with this particular webinar in regards to the correlation of why we need to watch and address each of these particular nutrients, but group of nutrients as we combine some of these. As you can see, the first row involves the B vitamins, and as you know, there's 8 B vitamins on this particular testing. And in this particular patient's case, you can see none of them are really robust. She has some levels that are normal, like a B1 or B3, her folate and biotin are normal, but you can see they're barely normal, that they're all right there touching the yellow, so they're getting ready to go into the borderline deficiency state. And once again, I want all my squares with my patients in the mid-white, but correlating this, you will hear me talk about this today, about B6 and how B6 affects certain hormones. And you also hear me talk a little bit about the methylation process. However, I'm going to cover that more in the next week's webinar involving thyroid and MTHFR. So once again, this is something we have to correlate. And then, of course, there's always that situation of homocysteine and how homocysteine affects us. And we talked about this last week in regards to homocysteine and how it is a cardiovascular marker. But once again, it can be affected by thyroid function and other hormones. And I will bring that up today on how certain hormones can affect nutrients in the homocysteine pathway and lead us down the road to either stroke or cardiovascular disease. In addition, how homocysteine also can affect our skeletal system, and that's very important because, as you know, thyroid dysfunction is associated with osteoporosis, and so we have to keep that in mind. And homocysteine, which is a marker that should be used for osteoporosis but is not often used by clinicians, but has been, once again, confirmed in the literature to be a marker for osteoporosis. The amino acids and metabolites, as you can see, this is where we involve 4 amino acids, and those are, of course, serine, glutamine, asparagine, and carnitine. And then, of course, the metabolites are choline and inositol, and then, of course, there's an omega-9 fatty acid that's noted here. As you well know, it's oleic acid. What's interesting about this particular patient, and I will correlate this with further slides today, is the choline and inositol, how both of those nutrients are involved with hormone/thyroid dysfunction. And, you know, we always talk about did this deficiency cause this problem, whether it's hormone, whether it's cardiovascular disease, whether it's diabetes, osteoporosis, whatever, or is it actually a hormone deficiency or change that alters our nutritional status? And you will see that today. We're going to go in a little reverse way of looking at things today, because usually it's a nutrient deficiency that causes a pathology. In this case, it's actually a hormone deficiency that causes this particular nutrient deficiency, and that's choline. And so it's a different way of thinking, of not just thinking nutritional deficiencies cause pathologies, but do certain pathologies or certain changes as we get older actually affect our nutritional status. And I'm not just talking about absorption type of changes. I'm talking about actual hormone production changes. And that's really important. Or if someone takes a hormone, how is that going to affect nutritional status? And definitely will. And you'll see some of the correlations with this. Because as we all know, when people come into our office and they're talking about dry skin, fatigue, hair loss, bowel changes, maybe possible lipid changes, of course we think about thyroid dysfunction or hormone dysfunction, and we need to address that. Well, because of the aging process or because of the thyroid function or the medication prescription dosages, it may once again alter some of these particular nutrients, and that's a secondary thing. So you may not see that initially, and what I mean by that is a person may have a situation where they've gone from normal menses to perimenopause or menopause, and within a few months or maybe a couple years, that now, because of their change in their hormones, they're actually affecting the nutritional status. And that's, once again, very important to keep in mind. The bottom row of the first page, of course, this is where it includes the minerals and the majority of your fat-soluble nutrients. Of course, the D, the A, the K, but then, once again, your minerals. And you can see there's one deficiency, and it's vitamin D, and then there's a few borderlines. And just due to time restraints, I'm not going to be able to cover everything here on this, but there, I have performed some other webinars for SpectraCell. They are archived, where we talked about hormone dysfunction and the micronutrient test, and I would recommend that you follow up with that particular webinar as well. And there's other individuals that have also done some very good webinars that have been archived and could also correlate with this subject as well. But the point is that I'm going to show you some major relationships with these nutrients and why we need to watch these. And is it really the nutrient deficiency that's causing the problem, or is it the hormone change that's causing the nutritional deficiency? In some cases, it can actually be both. Another thing that we look at with the micronutrient test, of course, is carbohydrate metabolism. And I'll show you how certain hormones will affect this through an indirect effect on nutrient either production and or utilization. And as a result, a person may go towards a hyperglycemic or diabetic state, and this is going to be, once again, looked into through the cardiometabolic testing that I spoke about last week. So once again, chromium, as you know, is a major player with insulin resistance or insulin receptor sensitivity, as well as the correlation with chromium deficiency and elevated cholesterol, which we know is a common finding with hypothyroidism. The individual antioxidants, this is what most people look at, of course, and we should look at, but not totally look at this as the means of affecting our SpectraCell. And this is what I was talking about earlier. So here you can see that there are 7 nutrients that are on the individual antioxidant row. But as you will see later today in the slides to come, that there are other nutrients that play antioxidant roles. And because of these antioxidants role, we have to include them and as more or less a factor with the SpectraCell. So it's very important that you look at these nutrients as well as other ones that I'm going to bring up in a little bit here. The second graph, once again, this is where we are looking at the whole group of measurements that I talked about recently, the carbohydrate metabolism, of course, the SpectraCell, the immunodex, and the individual antioxidants. And, of course, the numbers here are the numbers that correlate or make up those graphs. And the nice thing about SpectraCell production and or reporting is that if you have a borderline value that they note that in blue, as you can see, and if you have a patient that has deficient status of a particular nutrient that's noted in red. So it clearly reveals to the patient that there are some issues. And as I've told my patients and I've told other clinicians, you want that column where it more or less is reporting borderline or deficient to be empty one day. We don't want any borderline or deficient words in there, and once again, are important and are correlated. So as I mentioned, we're now talking about hormone reports or hormone report findings, and as you can see in this particular one, there are some changes in the follicular stimulating hormone. The progesterone is abnormal and testosterone is abnormal. Now, there's 2 different ways of reporting, and you'll see this here in a second, where SpectraCell has this type of graph, which some people like, and then we have a different type of graph, which other people also like and prefer. But the point is this, are there some things on this report that are noting or indicating to us that something is going on with this particular individual? And of course there is, because we know that when a woman is going into menopause, whether it's perimenopause or full-blown menopause, that the luteinizing hormone and follicular stimulating hormones will often increase. And so when you are reporting this, or when you are getting this report on a patient, it's very important, and I can't emphasize this enough, that when you send a female out for reporting, or testing, I should say, is know where she is in her menstrual cycle if she is still menstruating. If, of course, she's in menopause, then it doesn't matter, but if she's going between perimenopause and menopause, where she's still having some menses, whether it's every 28 days or every 45 days or whatever, you want to know if she knows where she is. Is she in the luteal phase? Is she in the follicular phase? Where is she? The other thing is document, is she taking any hormone therapy? And that's very, very important. So a lot of times when I talk to clinicians and we go over this report, I will say, well, where was this patient? Because SpectraCell often will put the person in the luteal phase, or they'll document it as if the patient is in the luteal phase. Now, of course, they're doing that across the board because they don't know, unless you as a clinician note that, and then even if you didn't note that at the time, you noted somewhere in your chart of that patient that when you get this report, oh yeah, that patient was in the luteal phase when I sent her down to the lab to get her blood drawn. And so then you'll take all these numbers and you will correlate it with the luteal phase. On the other hand, if it's a follicular phase, you will correlate it with the follicular phase, and if it's in the postmenopausal phase, then of course that, or if it's postmenopausal treated phase, then you will also put in that. But the point is this, is that we have to put it in accordance with that particular phase, because otherwise we're going to get this in a situation we're not really sure. So for example, if you look, this person is actually postmenopausal. We know that because of her age. And once again, you see this 12.6 in the luteinizing hormone. Now, in the luteal phase, it's normal. In the follicular phase, it would be abnormal. And in this case, it's the postmenopausal phase, and so we know that that falls into that. So once again, we have to correlate it with that. So even though it's not highlighted as low or high, that we have to know where the phase is. And of course, in this case, we know it's in the postmenopausal phase, and so it would fit. Now, if a person was in a situation where they were in the they have normal menses, they were, say, childbearing years, say they're 30-some years of age, and they're taking oral contraceptives, then you have to, of course, know that as well and see where that comes into play with these various phases. So it's one thing that is really important to note, and it's something that is important to the patient, because say the patient comes into your office today and you give them a requisition to go have their test performed. And say they're right now, as they're in your office, they're in the follicular phase. And then something comes up in a couple weeks later. They, due to the busy schedule, they weren't able to perform the test today. And so a couple weeks from today, they go and have the test performed. So now they're going maybe from the follicular phase to the luteal phase. But you document, oh yeah, they went to the office, they went out of the office today to do the testing, but yet, because of time restraints, because of their hectic home schedule, they weren't able to do that, and once again, they went 2 weeks later, now it's the luteal phase. So just make sure you emphasize it to the patient, as well as you document in your notes where this patient is in their menses, if they are still menstruating. So once again, we're going to talk about this, and as you can see here, the progesterone, as I mentioned, is low, the testosterone is low, and the follicular stimulating hormone is abnormal, it's high, which once again, as I mentioned, would be indicative of the menopausal state. One thing I want to point out, because it's not noted with an H or an L, but it's very close to being abnormal, is the DHEA. The DHEA, you can see, is low normal. It is right at the range of becoming abnormal low. And so, once again, it's something else I emphasize to you, is when you get these numbers, even though they're noted in black as normal, look over to the right and see how far into that range they are. Because we all know that a borderline hormone level or a borderline nutritional level may be symptomatic and may actually be the relationship of the nutrient or hormone to the cause of certain nutritional deficiency or a certain sign and symptom, depending on if we're talking about nutrient deficiency or if we're talking about a hormone deficiency. So keep that in mind once again as I go into the future slides here and show you some correlation with the DHEA and some of these other hormones. So here's the steroid synthesis path, and of course this is a very elementary schematic here. There's a lot of other things involved in here, and cofactors and coenzymes and so on. But the point is, you can see here how cholesterol is required to start this steroid synthesis path. And so this is when we have too low a cholesterol, how we can affect all of these hormones. or these pre-hormone-like products. If you look at here, the DHEA, as I mentioned, was borderline, and that's responsible for, once again, making these hormones here, especially the androstenedione, and this is one that SpectraCell does measure. And so you can see the testosterone as well, and how this particular one can be affected when we affect DHEA. So the indirect measurement of DHEA going to androstenedione and then eventually testosterone. And this is how, when people give DHEA, they actually get some testosterone production. And it's an indirect way. So this is why that borderline DHEA that I just showed you, how that's very important in this particular case, because the person did have a low testosterone level. Now, as I mentioned, is it more or less the chicken or the egg? Did the nutritional deficiency cause this hormone imbalance, or did the hormone imbalance cause the nutritional deficiency? Well, you can see here that B6, a pyridoxine, has been shown to be a regulator of steroid hormones, and especially, as we mentioned, estrogen. And so when we have someone that is deficient in B6, that we know that estrogen regulation can be affected. Now, one of the concerns, of course, with estrogen is skeletal integrity. So you have a patient that comes in, of course, they have osteopenia or osteoporosis. They've been put on estrogen therapy to help their individual maintain, once again, their skeletal system, and yet this particular nutrient or hormone, may be affected by this nutrient B6. This is why B6, this is one of the reasons why B6 deficiency has been associated with osteoporosis. And that's why I know all of you have seen the same thing I've seen in my office, where a patient comes in, they're osteopenic or they're osteoporotic, they're taking hormone therapy, or they're taking some medication like a bisphosphonate, and their follow-up bone mineral density study is worse than it was 2 years ago. Well, if they've had some deficiencies like B6, that definitely can do that. And even though they're on calcium and vitamin D, if, once again, they're B6 deficient and no one's addressing the B6, it doesn't matter how much calcium or vitamin D they're taking. They're going to go into further osteopenic or osteoporotic state. So you can see that we've known this for years, and so I've given you some more current literature in regards to the Journal of Clinical Endocrinology and Metabolism in 2010, and then I've showed you where it goes back into the 1980s, and where we've seen in biochemistry journals that B6 was important in relationship to estrogen. So once again, this is why it's so instrumental that we look at multiple nutrients when we are addressing a situation like osteopenia/osteoporosis or hormonal balance in an individual. That just isn't hormones that they need to be taking, that there's some nutritional products that they need to be taking as well or maintaining. Vitamin D. There's some evidence out there that vitamin D supplementation might increase testosterone levels. Well, if you've listened to some of my previous webinars, depending upon who you read out there and who you listen to, but I think it's safe to say that anywhere from 65 to as high as maybe 80-85% of the U.S. population may be vitamin D deficient. And if you've also been paying attention to the TV and commercials or advertisements on hormone therapy, you see there's a lot of information out there as far as pushing testosterone patches or injections or pellets to help a person's testosterone level. Well, my question to all of you and to those patients is, have you determined your vitamin D status first? Because maybe their testosterone level is low because vitamin D deficiency or alterations, and instead they're taking testosterone. Well, the problem with that is this. Yes, you may correct the testosterone with testosterone, but you're not correcting the vitamin D with the testosterone, whether it's a patch, whether it's injection, or beads or anything like that. So you still have to address the vitamin D, and if you don't address the vitamin D, now we're pushing the person down the road to diabetes, if they have a deficiency, osteoporosis, maybe cancer or some autoimmune diseases, cardiovascular disease. So there's a lot of pathologies associated with this nutrient deficiency besides the involvement or relationship with testosterone. So once again, you can see this came out of hormonal metabolism research in 2011, so not too many years ago. As you can see, one of the things I mentioned about the micronutrient test is, of course, the SpectraCell, and I indicated that besides the individual antioxidant row that is on the second page of graphs, this is where you have to look at other nutrients that have antioxidant qualities. And vitamin D now is documented in the literature as having antioxidant qualities, how it is related to decreasing inflammation, and how you can see that the relationship of testosterone to estrogen is once again correlated to vitamin D. Once again, this has been present in the last 5 years, some of this research and some even before that. But the point is that when we are looking at the SpectraCell and the micronutrient test, and in this particular patient, if you remember, her individual antioxidant row was normal. There was 1 or 2 that were borderline or close to being borderline, but they were not in the yellow yet. But yet, if you remember on this person's micronutrient test, they did have a vitamin D status that was low. It was deficient. It's functionally deficient. She also had a testosterone level that was low. Now we know that in men the testes produce testosterone, and in women ovaries produce testosterone, related to that. But the production also comes down to the nutrient availability. So even though those tissues make it, they need nutrients to make the hormone. And the point is that yes, she's going into menopause or she's in menopause, and because of her various state with the LH and FSH and that are correlated with it, the DHA we also know is below normal, but she also has a vitamin D deficiency. So you can see there may be several factors that come into play that actually are involved or related to her low testosterone level. You can see the estrogen-progesterone relationship. Once again, you've probably all read or heard about how vitamin D actually may protect against cancers. There's definitely research about vitamin D relationship and possible reduction or prevention of breast cancer. We also know that vitamin D, supplementation of vitamin D adequacy has been shown to decrease prostate cancer and colon cancer and various other cancers. So vitamin D just doesn't involve, of course, breast cancer, but in this particular case, when a person may have an estrogen-dominant type situation or a progesterone-dominant type situation for breast cancer, that vitamin D may modulate that whole mechanism and, of course, decrease the chances of that. So it's very important, whether they have a progesterone involvement or estrogen involvement, that vitamin D is adequate. And as I mentioned earlier, there's at least 60 to 65% of the U.S. population is vitamin D deficient, and I think it's one of the reasons that we are looking at this nutrient deficiency and the acceleration or continued problem of cancers. Now, one of the nutrients that plays a very significant role with thyroid is zinc. What is also interesting about this mineral is you can see it also infects LH and FSH. And you can see this was discovered way back in the early 90s, and actually there's some literature even before that that was shown. But the point is that this person has a borderline zinc, and you may say, okay, but wait a minute, these levels were, one was high and one was normal. The point is that this person also had an involvement with thyroid dysfunction, could have thyroid dysfunction, and zinc is related to the thyroid receptor. And it's the first nutrient that I look at whenever a patient comes in and says they have thyroid dysfunction. The first nutrient I look at in the micronutrient test is zinc. And I would say it's probably safe to say, especially if they're hypothyroid, that they possibly have a 60 to 70% tendency to have zinc involvement. Now, it might not be a full-blown zinc deficiency, but it's probably at least a borderline zinc deficiency. Now, if they do the whole female panel or hormone panel, whether it's male or female, and we look at the abnormal LH or FSH, once again, we have to know that connection as well. And this is the main point I want to emphasize, because you'll see that there's other nutrients as well that come into play. So we can't just look at LH or FSH and say, oh, let's take zinc, or let's take B6, or let's take vitamin D, or whatever the case is. And that's what's happening. I know you see it, because I see it in my office all the time, where patients will come in with general tests, hormone tests like the hormone test here or the thyroid panel, and because something is off, a clinician has just thrown a nutrient at them. They don't know if there's a specific deficiency, but they know there's a correlation, a possible correlation with that, and that's when they will send that patient out with that nutrient, rather than doing a micronutrient test and specifically saying, yes, you do have a zinc problem or a vitamin D problem or something like that. Now, this is where I was talking about earlier about the chicken or the egg. And this is a good example on how hormones can affect this particular nutrient. Now, this nutrient, as you know, has several implications. It's involved with cell membrane quality. It's responsible for acetylcholine synthesis. It's involved with the liver and gallbladder for bile acid production and maintenance. And, of course, it is going to be affected by hormone production. And this is very important. This is also, you can see on this slide, on how someone's genetic makeup can affect an enzyme or enzymes that will eventually affect the choline synthesis. And so when you're looking at a particular nutrient deficiency on the micronutrient test, it could be the lack of a hormone that is actually causing that, rather than the other case where vitamin D deficiency is causing a decrease in testosterone. So this is the reverse to that. And once again, you can see that we need certain enzymes in the body to make this particular nutrient. For some of you that have been in the field a long time, you probably realize this, and you've heard this before. Choline and inositol used to be included as the B complex, and now people, of course, have separated them out over the past several years, and for the most part, they are not considered B vitamins. But sometimes you will see choline and or inositol on a B complex, and it's because they're very synergistic with those particular B vitamins. But once again, generally speaking, choline and inositol are not B complexes, but they are, once again, synergistic. So you can see here, one of the major reasons for choline production is estrogen. And estrogen, as we all know, will go down in an individual, in a female, as she ages in perimenopausal and eventually menopausal phase. But think of this also. If a woman has a surgically induced menopause, so she has a total hysterectomy where her ovaries are taken out, her estrogen level drops significantly, and now she's going to have a situation that she doesn't have the hormone anymore to make choline. Now, why is this important? Because choline deficiency can cause neurological problems with the relationship with acetylcholine. It can cause biliary problems like fatty liver. It can also affect, of course, our triglycerides and cholesterol level, and also our overall absorption of fat per se, because of the involvement with being into a bile acid. So one hormone deficiency or decrease can totally affect our choline level. And so taking that into consideration, of course, you realize that the male individual is going to have a better chance of a choline deficiency than the female, until the female, once again, hits perimenopause or menopause or surgical menopause. And that is noted, you can see in the third bullet, where men and postmenopausal women both have an increased risk of choline deficiency. Now, what's interesting about this is it's one nutrient that I see often deficient in athletes, so people that are active. So when people are active, we know that choline deficiency is a little bit more prominent, and choline deficiency can cause muscle cramps. In fact, I've seen numerous patients that have severe muscle spasms. They've been trying to get treated with potassium and sodium and magnesium and various other electrolytes, and they consume a lot of water, and they say, I drink a lot of water, I take all the electrolytes, and I still get muscle cramps. Well, this is one of the reasons. Why? Now, if you look towards the bottom of the slide, you'll see that there's a large percentage, almost 75% of women have at least an abnormal genetic tendency for the PEMT enzyme. And as a result, that mutation on that particular product or affecting that product can cause these deficiencies. So when you see a choline deficiency in a female, is it one, due to estrogen levels that are not adequate, or is it actually due to the PEMT? And once again, this is something that you have to rule out. And you can see there's SNPs that definitely have been looked at or found with this particular enzyme. Inositol, as I mentioned, inositol and choline have also and often been looked at as B vitamins. But they are not really truly considered B vitamins in the biochemical field. But people see them in, once again, those types of products. How does inositol affect hormones? Well, on our previous week, we talked about possible inositol and insulin receptors, and that's something that's very, very important. And you can see here that we also know that myoinositol has been shown to be instrumental for FSH signaling. And this is one of the reasons why inositol actually it does have an effect on fertility. And people that are performing IVFs or people that are going through these infertility processes and maybe are not successful could be helped by a simple nutrient like inositol. And I see this quite often in my practice when couples come into my practice for fertility reasons, that one of the nutrients I look at right away or I talk about with them is inositol. And a lot of them have not heard of inositol. Of course, they heard about the B vitamins, they've heard about the minerals and the fat solubles, but they're not really familiar with inositol. So for those of you that are involved or want to really expand your practice in the OB/GYN field or fertility field, this is one nutrient you want to monitor very closely. Myoinositol and oxidative stress, as I mentioned, there's a lot of different causes of diseases, and one that comes up over and over in the literature is oxidative stress. And this is where antioxidants come into play. And you can see here that things like superoxide dismutase, catalase, those particular enzymes, and then we have glutathione. That's very important for controlling or modulating our oxidative stress. Now, we all know that superoxide dismutase is affected by zinc. We know it's affected by copper. We know it's affected by manganese. Here you can see that inositol may have a relationship with these various enzymes and this amino acid glutathione. And once again, this is quite new information in regards to publication, and you can see this was in 2011. So approximately 5 years ago, where they talked about myoinositol and oxidative stress. Again, we know it's involved with insulin resistance, as I mentioned, and very important in that aspect. One of the things that we often talk about when we talk about hormone imbalances is the condition of PCOS, and we know that this is a very common endocrine disorder affecting women. In fact, some people say it's the most common, and you can see that melatonin does have a relationship with this, and they've shown that possibly, once again, oxidative stress and the role with PCOS, and so it's definitely something to consider when you are dealing with a woman that has PCOS, because as you know, the common medication prescribed is metformin for PCOS, and they try to regulate the, of course, the hormones, primarily the testosterone. So you can see here that melatonin has been shown to be elevated in cases with PCOS. It has been found to be associated with, of course, the increased testosterone levels. And so this is something that may be beneficial to, if a person does have a low testosterone, to give them melatonin, but also melatonin doesn't just have that mechanism. It also has a mechanism of altering or affecting oxidative stress, which is very important as well. The synthesis, as you can see here, it is produced by an essential amino acid known as, of course, tryptophan. And what's important about that is we know that B6 has a relationship with tryptophan, that has a relationship with tryptophan and serotonin. So B6, once again, is very involved with that particular process. B6 also has a relationship with dopamine, so it has a relationship with some neurotransmitters, and here we have a relationship with, once again, melatonin. And we also know that things like estrogen can be affected by B6 as well. Now, generally speaking, oral contraceptives have a tendency to cause a few deficiencies, and two of the deficiencies that it does cause, or that group of medication causes, is B6 deficiency and or folate deficiency. And for that reason, whenever someone's been on hormone therapy for a while, we want to make sure that they are being checked for their possible deficiencies after taking hormones for several months or years. This is a comprehensive thyroid plus adrenal report you can see. So SpectraCell does the entire thyroid relationship here. You can, of course, also add a T3 uptake. That is not on this particular panel, but you can add it individually. But you can see here they check to see if there's any type of autoimmune situation. Of course, in the case of thyroglobulin, as you know, in the field of oncology, they monitor this for thyroid cancer, and something that should be the thyroxine-binding globulin. Once again, in this case, you can see it's low, and we'll talk about that in a second. And then you can see the T4, the total T4 is right on the edge. Its borderline is 4.5, and of course, this range is 4.5 to 12.5. What's also interesting is we know that T4 goes into T3. And if you look closely, even though it's not highlighted in any color, you can look over here at this graph and know it's getting close to the abnormal range. But if you pull it over here to this numeric range, that it's low normal. It's 2.5, and of course the range is 2.2 to 4.0. So what's important about that is this factor here, T4, going into T3 is being altered or affected, and by just looking right down to see, oh, well, there's no red around this particular number, that's good, you would miss it. And once again, this is why it's important to look at these numbers here, look over this type of graph, and as most people are visual in relationship with learning, that this will give you a quick idea that there's something close to being going wrong. This is, once again, same information, just a different way of presenting it. It's from a graph form. Some people like this because every other line is, white or light blue, and so it's easier to stick some things out there. But at the same time, I still recommend that when you look down these columns of numbers, that you actually look over to the right and see what the range is. And you can see this 36 and 35, so it's very close to being abnormal. And if you just look real quick, say, oh, there's no L or H next to it, everything's normal, you're really going to miss something that's very important. Personal note, I like to have my patients, male or female, their DHEA to be at least 150 to 200. So anything under 100 to me usually is symptomatic in a lot of these patients, something we should be looking at. Zinc and thyroid, as I mentioned, there's several functions with zinc and thyroid, but what's also interesting, as you can see here, in Down syndrome individuals, we know that there's often a zinc deficiency. And we also know in these particular group of individuals that they have a lower T4, they have a higher TSH, indicating, of course, hypothyroidism, and we know that zinc is very important for thyroid regulation. Well, having a condition like Down syndrome that's predisposed into zinc deficiency, we know it's kind of secondary that they may develop a thyroid dysfunction. It's kind of like a person that has celiac disease, they're on a gluten-free diet, and that has a tendency to push someone into B6 deficiency and selenium deficiency. We know how important selenium is and the deiodinases involved with the thyroid hormone production. You can see once again that zinc is very important for cell proliferation. So when we are talking about all cells replicating, zinc's essential for that, but not just for all cells, but especially the fast replicating cells. The cells like the certain epithelial cells in the GI tract or platelets that require, of course, replication every few days. So very, very important, and of course we do know that zinc deficiency has a strong relationship with thyroid function. But also you can see here that in the second bullet, thyroid hormones also influence zinc metabolism by affecting the absorption and excretion. So it goes back to choline. We know estrogen is related to choline production, and in this case we know thyroid hormone is connected to zinc by thyroid receptors, but also by the absorption and excretion of this nutrient. As I mentioned, oxidative stress, we've seen it highly related to numerous pathologies. You can see here that oxidative stress may be due to decrease in follicle quality as well as progesterone production. And so the follicle and the integrity of this particular structure is once again affected by inflammation and oxidative stress. Manganese, a nutrient that's noted in the micronutrient test, but really not talked much about. There is a lot of information on manganese, and maybe not as near as much as like B12 or folate or magnesium or calcium or something like that. But very, very interesting in the relationship of thyroid. Also has a relationship with cardiovascular disease, as you know, in regards to cholesterol or lipid maintenance. But the point is that we have seen how manganese is affected by thyroid hormones, and also how this particular mineral can affect hormones by affecting the deiodinase enzymes. And as you know, there's 3 of them. And when people talked about those enzymes, they primarily talked about selenium, which is true. It's more common or more frequently talked about than manganese is. Now, manganese is also, if we take too much manganese, can cause neurological problems, and they have seen some relationship with Parkinsonian type presentation. So we don't want to take large dosages of this particular mineral, but at the same hand, if they don't have adequate dosages and uptake, that we may, once again, push someone into thyroid dysfunction. So taking that into consideration, like I said, due to time restraints, we have to limit to certain nutrients and that. But the point is this: I think you get the idea from the previous 3 weeks, the one talking about thyroid dysfunction and hormone dysfunction in the micronutrient test. We talked about thyroid dysfunction and how it affected the cardiometabolic panel. And then we actually today looked at the different hormone panels, the thyroid adrenal panel, and then the, once again, the male and female hormone panel, and how those hormones can be affected by nutrient intake or adequacy, and or how certain hormones like estrogen can actually cause a deficiency of choline because of the lack of production of this nutrient and that hormone. So whenever you're looking at these particular nutrients, it's extremely important to say, is it going to be deficient because a lack of a hormone, or is this deficiency causing the lack of a production of a hormone? And so that's why it's so important to look at all these nutrients at one time, because some of the nutrient deficiencies may actually be decreased in hormone production, and that decreased hormone production may affect the production of a nutrient such as choline. Then, of course, we have to look at nutrient-nutrient interactions. Zinc we talked about was very important, and how zinc and copper always go together, and how calcium and magnesium go together, and how vitamin D, calcium, magnesium, vitamin K, and all those go together. And I didn't really talk about it much, but I do want to mention at this point how this particular panel, the micronutrient panel, will also give us some indication, are we going down the road to an autoimmune disease? As I mentioned, we know vitamin D deficiency is associated with autoimmune. We know that asparagine deficiency is associated with autoimmune. We know that selenium deficiency is associated with autoimmune. So when a person comes in, they have an autoimmune disease, and then they might have a vitamin D deficiency or selenium deficiency. Which came first? Was it the selenium or vitamin D deficiency that affected the immune system? Now we have an autoimmune condition, or was it the autoimmune condition actually caused the nutrient deficiencies? So, you know, sometimes we don't know which one came first, but there might be both present. And so we have to address both of them, whether it's the hormone production and or intake, and also the nutrient products. And also another thing is follow-up. Is we may start at what we call a therapeutic dosage, and that therapeutic dosage may satisfy 85 to 90% of all patients, but the other 10 to 15% may not benefit. And as a result, those people don't get better. And those people might go down the road and say, well, I tried that nutrition stuff and it didn't really work. Well, no. Once again, you have to realize that it may not be the dosage and the length of time. In fact, I was reading some articles the other day, and it was very interesting. They were talking about supplementation of certain nutrients, and they weren't correcting or affecting a certain disease. Well, the problem is, in some of these studies, they went 8 weeks, 12 weeks, and some of the nutrients that they were looking at, for example, like CoQ10, may take up to 3 to 4 months to build up to an adequate level. So if a person is doing research on CoQ10 and they do the beginning research, and then by the time it gets done, it's 3 months later, it may not have been an adequate amount of time to actually fulfill the CoQ10 dosage that was going to be adequate. And then the person says, oh, I tried that CoQ10, it didn't work. Well, no, you didn't saturate the tissues and actually get it to the point where it would be beneficial. So, once again, I think it's very important that you keep all these in mind. Go back to some of the previous webinars whenever you talk to some of the consultants for SpectraCell. Once again, you will hear some of the same information come up. But the more and more you use these testing procedures, you'll be able to get to the root of the problem and help those people from a biochemical standpoint. Also, if you have any questions, you can always submit those to SpectraCell through these particular ways. And once again, a representative will contact you in a short period of time after getting those questions to answer those questions, or at least direct you in a manner to help you research the subject yourself. So I want to, once again, thank you for listening today, or once again, this broadcast is taped, so you can listen to this at any time, and look forward to the next session where we will be talking about thyroid and how it may be related to the MTHFR, ApoE, also possibly the comprehensive metabolic profile, and the CBC. Things that are commonly ordered, but once again aren't really noted to be abnormal because they're not quite as sensitive as we might have thought, that we have to do some more sensitive testing like the micronutrient test to really catch things at a very early status. So once again, thank you, and look forward to talking with you in the future. Thank you.